Hi, in this short presentation we're going to be covering the pathophysiology and treatment of pulmonary edema. So pulmonary edema is the collection of fluid in the lungs. Now, one thing that I want you to realize right away is that it's not so much the fluid in the airspace that's causing the problem. Rather, it is fluid in the interstitial spaces. If you take a look at the picture on the right side of your screen, you can see a normal capillary bed on the left, and then a fluid-filled one on the right. What you notice is that there's a larger wall that's between the alveoli and the actual blood space. Now this interferes with the diffusion of gases across this space. It should be a thin membrane, as you see here. Very thin, that allows real free exchange of the gases. Once fluid accumulates inside this space, it's a greater distance apart and you have difficulty with this gas exchange. So you end up with a retention of CO2, lack of oxygen coming into the body, interferes with the entire process. Alveolar respiration is decreased. And that's the main problem that we have going on. It's not so much fluid inside the alveoli, but rather the gas exchange from fluid inside the interstitial spaces. So this may be something that develops over time. It may be something that happens very quickly. Oftentimes this accompanies incidences such as AMI. If you have a sudden decrease of left ventricular pumping function, then you have a backup of fluid into the lungs, much like we discussed in class. About 80% of MIs will have fluid accumulation in the lungs, shortness of breath, and this tends to be a fairly quick onset. This can also be something that builds up slowly over a long length of time, so that may also be a possibility. So the cardiogenic causes of pulmonary edema are referred to as CHF, congestive heart failure. But that's not the only cause of pulmonary edema. There can also be other causes that are referred to as ARDS, ARDS, or Adult Respiratory Distress Syndrome, sometimes also called Acute Respiratory Distress Syndrome. So there's a cardiogenic and non-cardiogenic causes of pulmonary edema. So patients that do have a cardiogenic cause can present with other signs of a cardiac emergency: pale skin, sweaty, may or may not have chest pain. That one's really up in the air with cardiogenic emergencies. And then non-cardiogenic ones may have a hypoxic episode, maybe showing signs of trauma. If you have a contusion to the lungs, that's going to cause some fluid collection. Or any kind of history of inhalation of toxic gases or sudden changes in terms of altitude can also cause some acute respiratory distress syndromes. All patients should have some difficulty breathing, particularly when they lie down flat. Think about it as a bucket of water. If you lay down flat, that bucket of water is going to flow up and come out the top. It's very much like your lungs. If you're sitting straight up, the fluid sits low down in your lungs. If you lay down flat, it's going to fill the lungs from bottom to top. So these patients, you never want them lying down flat. In terms of lung sounds, crackles or pulmonary growls are the common sound that you'll get with it. So one of the biggest confusing points for students is understanding where growls come from. Growls do not come from air passing through fluid. That sound is rhonchi. Growls come from the reopening of alveoli towards the end of inspiration. So if we go back to our fluid-filled interstitial spaces, this puts pressure on the alveoli. When the patient breathes out, that pressure causes the alveoli to collapse. When the patient breathes back in again, those alveoli will snap open when you have enough pressure to reopen them. It's that snapping open sound that makes pulmonary growls, and it's a good indication that you have fluid in the interstitial space. As the patient gets worse and worse, you should hear those growls rising higher up inside the lungs. Eventually, when the patient is profoundly affected, then you should have diminished to no lung sounds lower down and growls present up top. Those sounds you want to listen for towards the end of inspiration. So when we talk about the non-cardiogenic causes, toxic inhalation is one of the more common causes. So it's like when you're cleaning things up at home. There's a reason that you never mix Clorox and Lysol. You ever put ammonia and bleach together? You make chlorine gas. When chlorine gas comes in contact with water, such as the water inside your lungs, it's going to become hydrochloric acid. This kind of toxic inhalation is going to cause rupture of cell membranes, damage to tissue, which is going to cause your body to shift fluid in the direction of that damage. So that's one of the examples of an adult respiratory distress syndrome, a non-cardiogenic cause of pulmonary edema. So in the assessment and management of these patients, oftentimes you're going to end up giving these patients high concentration oxygen. They're having a difficult time making these gases exchange, so giving them oxygen to help move that oxygen from the alveoli into the bloodstream is typically a good idea. In terms of placing the patient in the position of comfort, well, almost needless to say, putting this patient bolt upright is going to be the most comfortable position for them. In fact, most of these pulmonary edema patients, if you lay them down flat, they don't just go into respiratory arrest, they go into a full cardiac arrest. So these patients in full Fowler's position, with the legs over the side of the stretcher, will help displace more of this fluid farther on down into the lungs. And really help out their breathing quite a bit. Other treatment that you can initiate is based on their respiratory status. You may need to start assisting them with ventilation. So oftentimes you'll have them breathing rapid and very shallow. So bringing out your BVM and assisting them on about 10 breaths a minute to help gather a little bit more volume tends to be a good idea. IV access is a relatively low priority. Farther down the line, there are different medications that you can give them to help move some of that fluid out. But you want to be very careful with your flow rates. These patients are flooded. If you have your IV run away on you, you dump an extra half liter into this patient, they'll be just that much more flooded. You're basically dumping that fluid into the lungs. That's not going to help them out very much. So when you do establish the IV, either do it with just a saline lock or make sure it's going no faster than TKO. Administration of fluid at this point in the patient is likely to be fatal. So then rapid transport is certainly indicated here. One other treatment that you can also initiate is going to be CPAP, continuous positive airway pressure. That is addressed in its own presentation, so please refer to that presentation for the use of CPAP in the treatment of pulmonary edema.